Good afternoon, everybody. We're thankful to have everybody joining us. We're going to get going full speed here in just a couple of minutes. For those of you who don't know me, my name is Wess Long. I am the president for StarGuard Elite. We are very happy to have so many people here from so many parts of the world and throughout the United States. We're looking forward to speaking with you all today. So today's focus is going to be largely based on the StarGuard Elite COVID information considerations and best practices guidelines that were released on Monday. It is a document that is internal to StarGuard Elite training centers. However, there's a lot of best practices in it. And today we have Dr. Justin Sempsrott, the SGE's medical director, that will be sharing a lot of information shortly. We'll bring Justin online. So I'm going to shift gears just a bit and talk through just some housekeeping before we get going. So bear with me here. So from a housekeeping standpoint, this information, this meeting is for informational purposes only. We do know we have a lot of non-StarGuard Elite clients joining us and people from various facilities and other agencies, and we're thankful to have you here today. The information, please follow your local agency's guidelines and medical direction. This meeting will be available on our Facebook page after the meeting. And we'll have a brief Q&A. We'll be answering questions as much as possible, but we are set for a 1-hour presentation and may only go over that just a little bit. We will share our direct contact details afterwards, and you're welcome to reach out and contact us, and we'll be happy to assist however we can. So So all the information, it's going to be general, and specific application may vary, but ultimately we think that there's valuable information for any type of aquatic facility with any sort of agency out there. This information is being updated very frequently, and I think it's very important to notice that today's scope is going to be not in areas that are non-aquatic, such as cash handling and things like that. And we're not going to spend any time talking about blended learning, virtual learning, planning. Those are things that we've been talking about for well over 5, 6, 7 weeks now, and we're beyond that. We're looking at solutions. We're much further than being able to be at a point where the focus needs to be on just thinking ahead. We need to be taking action, and that's really where StarGuard and our focus is going to be. So this is a rough snapshot of what the guidelines look like. You can see table of contents. We covered a wide variety of topics. Justin is going to identify a lot of the guidance that's specific to medical direction and answer a lot of questions that are very common throughout the industry at this point. And the bottom left, we actually developed a operational checklist as well for clients to be able to learn more in terms of making sure that they're addressing all the little things that need to be happening and working through all of the various elements that come into play when we talk about operating in a COVID-19 environment. And then the last thing, I think it's very important that we keep in mind and we remember the timeline that we've experienced here in the last 7, 8 weeks. And so this timeline is a very high level, but it all started really March 12th was when we sent out our first memo. And at that point, we were still training, talking about new best practices. By the next week, we were still doing some training, but it was more of a proceed with caution, utilizing online training and blended learning resources that have been widely available for a long time. And then really at that point, we were talking about remote learning, remote recruiting and planning in advance and doing all of that stuff that now is getting to a point where we got to start implementing those plans. Throughout this, we've had a series of medical director updates. We've released the virtual training block plans. We've been advising the clients and training centers to where they're at from a training, stopping training pretty much through April. We thought early May might be a possibility towards the end of March. We're kind of on that timeline now with some areas. In April, the week of April 6th was a big week because we had a big medical director update, as well as we met with a lot of aquatic industry suppliers and shared a lot of guidance for them. And then we've continued to push out various updates, and based on the guidelines and guidance that's been released by places like the White House and the CDC. So this week was a big week for us, but we're going to see some more development. So I'm going to shift over and I'm going to bring Justin on board here. So Justin, can you hear me? Oh, hang on one second, Justin. Justin, can you hear me?
I can. Thank you very much.
Excellent.
Yep, absolutely.
Right. I'm going to go offline. I'm going to leave it to you. And
All right. Thank you guys all very much for joining me today. I want to first acknowledge those still working on the front lines, not just doctors and nurses, but the ancillary staff, housekeepers, delivery persons, grocery store workers, and many other minimum wage workers who face the choice every day of infection or further economic uncertainty and inability to provide for themselves or their families. I also want to say that there are 3,248,039 people worldwide who have been infected, with nearly 2/3 of those still in the active phase of their infection. The 229,313 deaths worldwide, with more than a quarter of those here in the US, are likely a vast undercount and are more than a statistic. Every single one of those numbers is a person like you or I with a life story and a family. These are certainly unprecedented times, and the degree of confusion and misinformation is staggering. Most importantly, we are all looking for messages of hope. Those messages of hope mean different things to different people. To some, hope is staying closed. To others, it means opening. As we watch this unfold in real time, I think it's fair to say that everyone is looking for concrete, definitive guidance and reassurance. I listened to and spoke to Justin Scarr, CEO of Royal Lifesaving Society Australia, yesterday, and he reflected that the rapid evolution of information in the age of COVID has created a new frame of reference for hindsight. While big decisions by leaders used to be measured in terms of months or years, and we would think, did I make the right call, and watch it play out? It's now measured in terms of hours and days. The statements that we make today may need updating even as soon as this presentation is done or within the next few days. And our increased understanding is evolving very rapidly. With that in mind, there is not going to be a one-size-fits-all approach to reopening, and you will have to consult your local health authority. Unfortunately, many local health authorities may not have aquatic facilities on the front of their mind. The industry ranges from law enforcement, EMTs, and ocean lifeguards to recreational water parks, municipal aquatic centers, gyms, backyard swim programs, and everything in between. Appropriately, the recommendations will require vastly different strategies and practical realities for implementation. The role of government as the primary source of data has been relegated to localities. The national leadership from the top down has adopted an approach of allowing individual states, counties, cities, and businesses to develop their own plans. We will see this play out in businesses that choose to open or stay closed in contradiction to state or city guidance. We see federal and state agencies allowing for reopening, but there is still appropriate fragmentation in implementation across communities as local governments and businesses conduct their own risk assessments. This has created significant confusion and interpretation of guidance that is heavily dependent on local expertise. The American Heart Association, European Resuscitation Council, and International Liaison Committee on Resuscitation have put out their recommendations, and the International Drowning Researchers Alliance, International Lifesaving Federation's Medical Commission, and International Maritime Rescue Foundation will have guidelines published within the coming days. This pandemic has highlighted a long-standing shortcoming in the aquatics industry: the lack of medical direction. For decades, our colleagues in EMS have recognized the need for local variation in protocols and practices that best suit their unique circumstances. These variations are vetted and implemented by physician medical directors with an understanding of the medical legal risks and the role of patient and provider safety, as well as medical best practices. As medical director of StarGuard Elite, a frontline emergency physician with subspecialty training in pre-hospital and disaster medicine, and a lifelong dedication to the aquatics industry, here are the best practices that I have developed for aquatic facilities under my leadership for reopening in the context of this pandemic. It all comes down to an acceptable degree of risk management and risk mitigation. These best practices must be implemented in the context of local guidance and resources and do not represent a one-size-fits-all approach. Staff and patron safety are the top priorities and must not fall prey to the tension between public health and economics. So with that, as I go through the presentation, there's going to be a lot of QR codes. So if you're on your computer, feel free to take out your phone. We will also post a link at the end of the presentation to be able to download this as a PDF, so you will have access to all of those links. While I'm in full screen mode, I can't see any of the chat and anything else. So Wes or any of the other moderators, if something's not coming through or if I'm frozen, you'll have to just text me. So first and foremost, I don't have any financial conflicts with any of the information provided. I will be showing some commercial products and naming them and their vendors by name, but I do not have any financial conflicts with them. Follow your own local protocols and medical directions. Here are my affiliations, but again, no financial conflicts. So briefly for nomenclature, the name of the actual virus itself is called SARS coronavirus 2. It is part of a family of viruses that cause the common cold, both in humans and in animals. COVID-19 refers to the disease caused by the SARS-CoV-2 virus. Colloquially, I will just call them all coronavirus or COVID interchangeably throughout the presentation, but coronavirus refers to the actual particle of the virus and COVID refers to the illness that it causes. The virus is spread in three main ways: through direct contact and indirect contact, droplets, and airborne transmission. Contact is somebody sneezes or coughs on their hand and then touches a doorknob and then you touch it, or they cough or sneeze directly on you. And what's coming out are big, heavy, wet droplets, and those fall quickly to the ground, but can live for several hours on some of those surfaces. Airborne is that those particles, the dried floaty ones, can stay suspended in the air for up to 3 hours. And so it may be that those particles are exhaled in the air and stay there for several hours until the next person walks in the room and breathes that air and then is able to contract the illness. So I want to talk about our response thus far in terms of the hammer and the dance. We have just finished the hammer phase and are now entering into the dance. So this was actually put out by Tomas Puello on March 19th, where we were starting to have a rise in cases. And if we did nothing, then the cases would continue to rise. So we all heard the concept of flattening the curve. Flattening the curve was bringing down the hammer, absolutely closing everything, restricting travel, restricting people getting out in order to learn about this illness. At the beginning of this pandemic, we did not have experts in the treatment of COVID. We did not have published peer medical literature. And now, here we are just 6 weeks into this phase since this was published, and we have physicians and nurses and physician assistants who have extensive experience and are able to share that experience with the rest of the medical community. We still don't have a vaccine, and we still don't have an effective pharmacologic treatment, but we can't live under the hammer forever. until a vaccine is readily available and utilized in mass scale, this virus is going to continue to circulate in society. And so that is the dance. The dance is that we need to continue to have people getting ill from this, but not at the same rate that they were before, and at a rate that is manageable. So I'm going to introduce you to the concept of R naught, or R subscript naught. I've heard it called R subscript T as well. And this is, for any given illness, the number of people that that one infected person can then infect. So for the flu, it's about 1.2 to 1.6. For COVID-19, without implementing the social distancing that we have under the hammer, it's about 2 to 2.5. And to compare it again to the flu, as I hear often done, there's a much longer incubation period, meaning that you have a lot of time of asymptomatic transmission. The fatality rate is higher, and the hospitalization rate is significantly higher. The creators of Instagram actually created this site. It's rt.live, and they track on a daily basis the R naught of every state in the U.S. And so you can see just 4 weeks ago that that number was greater than 1 in every state. And we want that number to be less than 1, meaning each sick person infects less than one other sick person, and that's how we will see a decline. As a result of physical distancing and the hammer, this is as of last night at 11:30 p.m. Eastern, that most states have fallen below 1 for their R naught, showing that we are successfully decreasing the rate of transmission. But the United States, or the world, is not one homogeneous population. And so even within the US, states have to do things differently. Those dotted lines in the back represent doubling rates. So Michigan on the far left has a doubling rate of about every day, whereas New York is doubling about every 2 days, and Florida is doubling about every 3 days. And it's easy to get mixed up in all of these numbers. And while we want an R naught of less than 1 and we want to maintain it less than 1, I think we can all agree that New York has been the hardest hit in the country. And even during their absolute peak of infections, their R naught was just 1.6. And their shelter in place shelter in place order went into effect when it was 1.2. And the difference between 1 and 1.2 is a 20% increase in transmission. And so these are small numbers. And further belying that every state needs to have their own plan, I've been working clinically in Nevada. So this is the daily situation report from just yesterday in the state of Nevada. And we see that cases continue to rise, but that rate of rise is slower. And some of this can be a lag because of the 1 to 2 week asymptomatic period in cases. All of this is just to say that our physical distancing efforts have been great, but we can't just flip on the switch and go back to normal, because then everything peaks back up again. And so we have to do this dance of getting back out into society, getting back out to interacting, and maintaining a baseline infection rate, or we stay under the hammer until a vaccine is available, which I don't think is practical. So the $1 million question that I keep hearing is, when can we train and when can we open? And the CDC has developed good interim guidance, and I recommend that you all comprehensively read through this. And just as a reminder, particularly for our international colleagues, is the Centers for Disease Control doesn't set policy. They say, from a medical standpoint, here are best practices based on what's available. Implement them however you need to locally so that you don't have to reinvent the wheel. Regardless of the politics, the Opening Up America guidelines came out a couple of weeks ago, and I think that they give a very realistic, very practical, phased approach to reopening. And before you can get to phase one, you have to have a 2-week period of a downward trajectory of COVID-like cases and flu-like illnesses. So as you saw on that graph for Nevada, it's slowing down its rise, but it's still not on a downward trajectory. And this, by using COVID-like cases and flu-like illnesses, it helps capture those cases that may not have access to testing, which continues to be an issue within the U.S. You also have to have a downward trajectory of documented cases and positive tests. So it's not just the suspected, but also the actual. And your local hospital has to be able to treat all patients without crisis care and have robust testing in place for all at-risk healthcare workers. And once you open your aquatic facility, your lifeguards are healthcare workers. And we'll talk more about this concept of the hospitals treating patients without crisis care. So these same criteria get you to phase one, and then doing these same criteria again gets you to phase two, doing these same criteria again gets you to phase three. And so at minimum, the getting back to normal is going to be a 6-week process at best. And that 14 days represents about 2 incubation periods to allow those asymptomatic persons to be seen. So for all phases, for employers, they must implement these. And just like drowning prevention for lifeguards, these measures here, as unflattering as they are more important than the CPR and drowning protocols. Social distancing, protective equipment, temperature checks, testing, isolating, contact tracing, sanitation, use of disinfection of common and high traffic areas is going to prevent far more illness than using appropriate PPE during training and during CPR. I want to highlight the concept of contact tracing. Contact tracing means if one of your staff members is positive, if somebody comes into your facility that's positive, you may need to contact everybody that was in contact with them, and then alert your local health department, who then will find out where they've been and who they've been in contact with. And most facilities don't have a register of everybody coming in and out of their facility on any given day, and that may be a reality if you are opening early in these phases. So most aquatic centers are going to, or facilities are going to fall into one of these categories, either large venues or gyms. And you can operate under strict physical distancing protocols, which is further defined in the document of gatherings of less than 10 people. So this is most likely where you're going to be doing training without necessarily having the public. During phase two, so now you're at 4 weeks of a downward trajectory. You're still closing common areas where people are going to congregate without social distancing. Moderate physical distancing protocols means up to 50 people. And gyms, as long as they are still doing strict physical distancing and sanitation, meaning nobody within 6 feet of each other, which is not practical for most aquatics facilities. And it takes 6 weeks, now phase three, to resume unrestricted staffing. And large venues can operate under limited physical distancing protocols, and gyms with no more physical distancing. So what does this mean for me? All staff and patrons should be wearing masks out in public. That means a big shift for a lot of facilities, and it means different things for different people to implement practically. The mask does not protect me, the wearer, from getting it. It protects me from being an asymptomatic person spreading it. So masks are most beneficial when everybody wears them. I'm going to stop sharing and go back to me for a moment. And these can be any material as long as they are 2 layers. So some have like the gaiter style that goes up and over. Some are using repurposed, so this was Water Safety Products. This is Original Waterman that's using repurposed swimsuit material so that it can get wet. And this is a homemade one from one of the nurses that from one of the places that I work. And Water Safety Products is as well doing ones that match uniforms. And I strongly recommend against the use of paper or disposable masks, either for staff or guests. One, they're uncomfortable to wear, but this thing has been catching my exhalation all day. And now if I take it off, set it on the table to eat, get up and leave, it blows on the ground. Now somebody's got to pick it up and it's contaminated with all of my saliva and exhalation. And it's just not practical. And so I really think that reusable masks are the way to go. So let's go back to sharing here. So that means we need to screen our employees and patrons at the gate, meaning nobody is getting in if they have symptoms of COVID-19 or have had contact with somebody within the last 72 hours. For some facilities, this is going to mean taking a temperature. I understand that for regulatory reasons, it's considered a medical procedure to take somebody's temperature, and will have to be voluntary or have somebody that's medically trained. And those are all local things that you will have to address. The benefit of the taking the temperature is that if you're opening up a voluntary recreational facility that is not essential, then somebody has the incentive to lie about their symptoms because they want to go in and have fun. And taking the temperature helps to identify those cases. Yes, it's still going to miss all the asymptomatic carriers, but that's one of the acceptable levels of risk that will have to be determined by each individual facility. And I include that or public safety access point in the US, that's 911. They are performing this screening as well. So for those of you that are responding to beaches where you can't necessarily close it and say don't come in if you have these symptoms, then that can be having the caller to 911 is asked questions. The person that the lifeguards are on their way to go rescue from drowning, have they had any of these symptoms? Have they come from any of these areas? And there needs to be a plan on how to respond once that person is pulled in from the water on what to do. For most 911 agencies right now, they're already doing that. And if you've got a gunshot wound or difficulty breathing, you're being asked these questions by the 911 center, and that's determining whether or not EMS is using PPE. So for emergency care updates, both the American Heart Association and the European Resuscitation Council have said there is no change except for known or suspected COVID-19 cases. And the only change for if it's not known or suspected is determined by local risk assessment, meaning if you're in a completely endemic area within the pandemic, such as New York City, where everybody's got it, then you might be treating everybody as if they're infected, even if they don't have symptoms. And I certainly hope that there are no facilities that are opening up during that time. More specifically, the International Liaison Committee on Resuscitation did an analysis and said, is there a risk of generating these aerosols during CPR and rescue breathing? And the answer was yes. And the American Heart Association put out their guidelines, which and start the same, verify seed safety, but there is an acceptable delay in putting on your personal protective equipment and limiting the personnel that are in the room, meaning if there's not people that are providing direct patient care, then they should be standing back 6 feet. They can be running and getting equipment or doing other things, but you shouldn't have more people at risk than usual. So for rescue breathing, but with a pulse, use a bag valve mask with a filter and a tight seal, and I'll show some of those in a moment. We should always have been doing a tight seal, and we've always been using a filter, but we've been using mechanical filters, and now we just need to switch back to the paper viral filters for a while. If they're not breathing and they're pulseless, same thing. We're still going to use a BVM with filter and a tight seal, and or use continuous passive oxygenation with a face mask during chest compressions, but none of these guidelines specifically address a difference in drowning. And professional rescuers are still held to the standard of giving rescue breaths and compressions in drowning. And I have made the decision for our facilities that we will still be doing rescue breathing in the water with a one-way mechanical valve until they get on the deck, because we've screened them and we've determined that their risk is relatively low of spreading it and of the person contracting it while in the water performing rescue breathings. And we want to still give that person the best chance at a neurologically intact survival. And the European resuscitation guidelines just came out a couple of days ago. And healthcare professionals should always use airborne precaution PPE during resuscitation for known or suspected. It doesn't apply to everyone else. Again, for known or suspected, use of a HEPA filter and use 2 hands to hold the mask and ensure a good seal. So a little bit of a reality check on the filters for BVMs. We used to always use these filters. These are the same paper filters that we used in the industry for decades, and only in the last 5 to 7 years have gone away from, because the water is not as practical in the aquatic environment, and we've gone towards more that either just have a mechanical valve instead of a paper filter. They do make other devices that are a separate piece that will replace the mechanical valve. It doesn't need to go in line with it. You can still do your mouth to mask this way outside of the water, and it still hooks up to the BVM. They've got the same standard 15 millimeter inner diameter, 52 millimeter outer diameter fittings. And a lot of our old CPR masks that we used for years in the industry all have these filters. This isn't a big shift. It's just going back, swinging the pendulum back for the way that that we've done it before, because now we're more worried about airborne transmission. And specific to our facilities, again, we are going to use those filters on every CPR case that we do, even though the guidelines only recommend for using them for known or suspected, because I want them to be available. I want the guards to be familiar with them and not scrambling for one if needed. I keep getting a lot of questions about PPE. PPE just means personal protective equipment. In law enforcement, that might mean a bulletproof vest. For lifeguards, part of our PPE is using gloves and sunglasses and a rescue tube. We've now come to associate the term PPE with using an N95 or higher respirator, face shield or goggles, gloves, and a gown. For aquatics facilities, we should be training and preparing the guards. If we choose to open and we say it's business as usual for non-suspected COVID patients, there may be somebody who comes through the gate that was asymptomatic, develops their cough and their fever while they're there. And we should empower lifeguards and give them the equipment and the tools that they need in order to care for those. So we will have the availability of N95 or higher respirators that have been appropriately fit tested, face shields or goggles, as well as gloves and gowns. And this is directly from the CDC website, where you have preferred and then acceptable use. And you'll see that the acceptable alternative PPE says N95 are preferred, but face masks are an acceptable alternative. Acceptable alternatives represent crisis care in the hospitals. In December, an N95 mask was a single-use disposable item that required annual fit testing to guarantee that it made a seal around the wearer's face. All of those regulations went out the window as a result of crisis standards of care, because there were not enough masks to make them disposable. And so now we're reusing these disposable things for sometimes several days at a time. As a recreational facility that is now opening to the public voluntarily, you have now transitioned from being non-essential to having essential frontline healthcare workers. And those frontline healthcare workers cannot be operating in a crisis standard of care, or you've opened too early, which means the supply chain, training, and fit testing availability of that N95 or higher respirator. What about in-person training and response? For the different phases, they give numbers for persons within that social distancing, and it's impossible to reduce the risk to zero. You're going to have to practice contact rescues, but for things where you can avoid it, 1 mask per person, 1 mannequin for performing breathing on per person, doing as much online learning as possible, then those things should all be implemented to help keep that risk low. But you're still going to have to practice contact rescues. You're still going to have to practice team-focused CPR, and you should be able to do that. Everybody should be wearing gloves. Everybody should be wearing their own cloth face mask. And Wes mentioned earlier the critical component of online learning. Again, my focus tends to often be on the medical treatment and the resuscitation, but these preventative measures like doing online and blended learning will often have more of an impact than the specific resuscitation part, though I understand that my portion of it is what causes people the most anxiety. So the hammer was successful. We did a great job with the hammer, but now we have to dance. And if we don't dance, then we have to go back to the hammer. And so it's not a matter of keeping the risk at zero. It's a matter of keeping that risk at an acceptable level. And that acceptable level of risk is that R naught of less than 1. So we mitigate risk where we can. We can't have everybody going back to work in a biohazard suit, or we've gone back to work and reopened our facility too quickly. So the vast majority of the industry is recreational, but becomes essential healthcare providers once we open. I love the example that a colleague brought to me a couple of days ago, and the idea of opening junior lifeguard programs. And if you were to follow these guidelines, these best practice guidelines, then it would be 2 weeks of a downward trajectory in your state before you bring in 10 staff, then 2 more weeks before you're at 50 participants, and then 2 more weeks before you're considering going full scale with those. And so that's a 6-week best case scenario before implementing something that's as voluntary as a junior lifeguard program, understanding that there are a lot of concerns that if we're not doing swim lessons, there's going to be increased rates in drowning, and all of those are very valid concerns that that we hope that we can mitigate. There's no major changes for non-COVID CPR. The changes in the guidelines are for known or suspected. Everybody has to innovate, because something as simple as disinfecting high traffic areas might mean something different for your facility, because there's a water feature that is sometimes dry. There's a water feature that's constantly getting chlorinated area. We have to reduce the number of people allowed in the locker room at any given time, or some very granular specific item. And there's not going to be national guidance on that. You are going to have to innovate and come up with your own solutions. And appropriately, implementation will require different timelines. We can't do everything all at once, because even within any given city, you're going to have different resources and different rates of infection. And that's why that local medical direction and involvement of your local health authorities is so important. So here is my contact information to send an email if you have other questions. And I had hoped to have the link available to share this presentation. Hopefully I'll get it within the next 18 minutes, and I'll get that posted as well, so that everybody has access to all of the QR codes. So with that, I will kick it back over to Wes. So I haven't been seeing all of the questions that come in, and go from there. And Jason, if you're on, I sent you a text. If you can grab a QR code for the file that I sent you, then I'll post that.
Thank you, Justin. And we will get it posted as well on a link that will be on the StarGuard Facebook page, posted later. So for anyone looking for it, this event again and the presentation will be available for download later today. So we're going to shift gears a bit. Justin, stay with us. I'm going to take your video off, and I'm going to go back to my presentation and walk through a couple more things, and then we're going to answer a few questions before we wrap up for the day. All right, bear with me here. So we're going to talk a little bit about some of the operational information. We've, like I said at the beginning, distance learning, blended learning, virtual training, planning, we're beyond that, right? That's the stuff we were doing in March, 3-4 weeks ago or beyond. And what we're focused on now is, what do we need to be focused on? What are we doing when it comes to getting these facilities open? So in the guidance, one of the things that we implemented, or we put best practices forth, was for on-duty lifeguards. It's not going to be the same, obviously, particularly wearing masks or how we rotate, contact points, rescue equipment, things of that nature. Everyone needs a cleaning and disinfection plan. This is not news. This is not unique. This is something that everybody should be aware of and have a procedure or procedures in place for. But it's important that you train your staff and you figure it out. We are getting the question, how do we disinfect every chair? How do we, do every single thing throughout the day? And that's where you're going to have to make your own best judgment in terms of what works for your facility. But it is not feasible. Just like if you go into a grocery store or something now, everything is not being cleaned between each and every person. However, you have to make reasonable efforts to have good facility sanitation practices in place. Water quality, the water quality on the next slide, I'm going to share a study that has been very loosely provided. It provides a lot of information, but by all accounts, there is no water quality concerns in any sort of chlorinated environment. We are still waiting for further guidance in natural still bodies such as lakes and rivers. At this point, there is not any concerns in ocean front or beach type front water lifeguarding, and that remains to be seen again as it develops. But definitely in chlorinated environments, there's no concern. From a physical distancing standpoint, Physical distancing really needs to be focused first on capacity control. You need to visit your facilities, procedures, what you're capable of hosting, whether it's based on the square footage, whether it's based on the types of activities, programming, attractions, whatever it is that makes your facility unique. That's what you need to start and say, okay, what can we operate and how many people can we do while maintaining physical distancing? But being aware that if we have to close all of those attractions or close these facilities, we still need the ability to have distancing where necessary. And so that's an important thing, not the expectation that we're going to kind of return back to normal, but everyone's going to stay 6 feet is just simply setting our staff and our patrons up for failure. Patron and staff education, everything from understanding policies and procedures to the physical barriers and the physical markings and things that needs to be in place. Again, that's been discussed for a month now. We're kind of beyond that, but just good best practice. And then this is something that I feel like goes without saying, but unfortunately we see a lot of conversation where people are saying, of course lifeguards have to enforce. Who else is going to enforce the physical distancing? And that is simply setting our operations and lifeguards in particular up for failure. Lifeguards should not be the primary person to enforce physical distancing. The distancing should be done through policies and procedures first, management and on-deck support second. Lifeguards can absolutely help if you say you have a 6-lane lap pool and you get 2 people in 1 lane, but your policy is 1 person per lane. They can absolutely say, hey, go to a different lane or wait, something like that. But in terms of regular routine distancing, absolutely not. We're setting the lifeguards up for failure there. In terms of the water quality, this is the study that was provided. I'm going to hide my mug, so the QR code is there. But this study was done on was provided on the National Institute of Health. It is a 2005 study that was for the SARS-CoV virus, excuse me. But what was very interesting about this were two kind of quotes in the summary element of it was that the SARS-CoV virus is inactivated much quicker than E. coli. And I know E. coli is something that as aquatic operations, we all worry about, but as long as our water is being treated, it's generally not as much of a concern as cryptosporidium or other recreational water illnesses. And then it says that the SARS-CoV can only persist as infectious particles for a very short time in vitro environments, and it's highly sensitive to conventional disinfectants. If you're looking for more information, that is the best study that we have found to this point, and it's definitely worth checking out. And then lastly, I would just like to say that we are absolutely excited to have so many people with us today, and we're really excited to be able to help our clients and guide through this process. If you'd like to learn more about either our program or get in touch with us, by all means, come check out our Facebook page, like and follow us, send us an email. We'd be more than happy to speak with you. Bear with me here. So I'm bringing Justin back on as well, but we're going to answer a couple of questions before we get off, but I want to talk about something that I think, to me, it's personal, and this is my own personal feeling. This isn't necessarily a StarGuard Elite position, but I feel that it's important that we as a aquatics industry find a solution and find ways to get our facilities open and be a service to our patrons, to our communities, to offer a recreational environment that families can go to and have a safe day. Risk mitigation, risk prevention, it is absolutely the core of what we do as aquatics professionals. Every day, we're mitigating risk. We never have had a 0% risk environment. And this is what we do. We do it better. And top of that, when we factor in the fact that we operate in a highly clean, very clean environments, there's chlorination involved that's going to help inactivate the virus. We can do this. And it's important that all of us make effort and really buy into the fact that it may not be business as usual. We may have to jump through a lot of hurdles, but absolutely, this is something that as an industry, it's pertinent. We find a solution and we find a way to make this happen. We got 6 to 7 weeks until most people's summer really kicks into gear. We got time. We've seen how much progress has happened in just the last 6, 7 weeks. We're kind of that middle point before we really get into full gear. Let's find a way. Let's make it happen. And I'm getting off my soapbox. And Justin, I don't know if you have anything you'd like to add to that, or if you want to tackle any questions that you've seen.
Yeah, so I'll kind of just get to some of the questions and the common themes. So the first is a HEPA filter on the CPR mask. It doesn't have to be a HEPA filter. It should be N95 or greater, and HEPA is greater than N95. Most of the old CPR masks that we used in the industry for decades had paper filters that met that standard, as long as they were kept dry and replaced annually. But they would get wet, they would get low quality. But a lot of the filters on other CPR masks moved away from the paper filter and to a mechanical filter. Even the little Z-shaped one that came on the old pocket masks had that little yellow flap of a mechanical filter in there. And that prevents their exhalation from coming up to you, but that exhalation still goes into the bag. That exhalation still goes out into the room. So this isn't necessarily a concern of their exhalation coming to you. It's their exhalation going out into the room and us trying to block that. That's why we're having that good seal, so that when they exhale, it goes back in through a filter before going out into the air. And then do we need to have N95 masks for our guards before we open? And the answer is, you need to have a policy or procedure or plan in place for the guest that raises their hand and says, I now have developed a fever. I now have developed symptoms consistent with COVID. I'm already in your facility. And if your answer is that everybody stays 6 feet away from them, regardless of respiratory distress, or just saying, hey, I have a fever, and then you call EMS, then that's what you do, or you escort them out of the facility. But if your lifeguards or any other staff are going to be providing care to them and within 6 feet, then they should have the appropriate protective equipment in order to do so. And I hear a lot of, go ahead.
No, I was going to add to that. Yeah. One of the ways that that's actually practically implemented, a lot of persons are understanding that to be every single individual has to be done this. That doesn't necessarily have to be the case. You can have a response team. For example, larger facilities might have a supervisor, a EMT medic team, things of that nature that are the ones that are trained. So as soon as that's the case, it's the burning building, so to speak. The people that are properly trained would then respond to that. Is that your take on it too, Justin?
Yeah, absolutely. And I think for me, the hardest question that I don't have the answer to is, what do we do when we have somebody call the facility and say, I was there 2 days ago and I just tested positive today, or that person that develops a fever, and your local health department can help with that. And they can tell you what other facilities are doing. They can tell you what the grocery stores are doing right now. And it might be that they just take that person's contact information. There's a standardized form that health departments are using. That's how we're getting these numbers nationally. But you're going to have to work with your local health department to help answer some of those questions. So the other big thing that I see coming up a lot, that I hear a lot, is this indoor versus outdoor. And doesn't UV light kill it? Yes, UV light inactivates and kills most viruses and some bacteria. We've used UV light for years in outside of operating rooms, but it's an adjunct. It doesn't completely sterilize everything. It doesn't do anything on the skin, and it helps with some surfaces. So it does help your cleaning. The biggest benefit to an outdoor facility is the air exchange, meaning the air that everybody's breathing is changing over more frequently than air inside of a building, particularly if there's any wind. But it doesn't reduce that risk to zero. And even outdoors, there is a benefit to wearing masks, because people that are exercising, people that are running around, laughing, screaming, and playing have increased respiratory rate. They're putting out more respiratory droplets. Obviously, we don't want anybody wearing a mask underwater. Obviously, we don't want anybody wearing a mask in a position that they're going to be going underwater. But if it's a splash pad, if it's, an ankle deep pool that the parents are sitting around, then that might be something to consider. And a question just popped up on mental health first aid, and I think that is probably the biggest sleeping giant amongst all of this that I've seen, not just amongst healthcare providers, but also patients as well. And I think that we're going to see the scars of that for years to come. And it is important to develop those procedures at your facility for the mental health coaching and checking in on staff to just say, hey, are you okay? I know it's stressful that we're having to do these things. I know it's stressful that somebody tested positive at our facility a couple of days ago. How can we be supportive through this?
Yeah, in regards to the distancing, a statement was made, or a question was made about, is it upon the guests? And it absolutely is. No different than if I go into the local grocery store or, a Walmart or something along those lines, and it's, Walmart's not chasing me and enforcing it, but there are certain measures and efforts that have been in place, and education points to try to tell people staying 6 feet apart. We are not going to be able to know whose family, who's not, that's their parent, their kid, things like that. It's just not going to happen. And so it's going to be a certain amount of calculated judgment, if you will. And so, so it's not ideal, but it's not we're not solving a problem that the rest of the world isn't also having to figure out as well.
And then if I could just jump on my soapbox for a moment, and that is, please, please, please don't make anybody get a doctor's note. If they say they're sick, they're sick. If they have symptoms, don't require that they get a COVID test. Don't require that they get a doctor's note. They need to be home for the guidelines are on there, but it's 72 hours symptom free or 1 week from the onset of symptoms, whichever is greater. And asking them to get a work note puts undue financial and social burden on them and the healthcare system, because now they're going to the place where all the sickest people are just for an administrative function. Obviously, they need to go to the doctor if they are sick or have symptoms, but if it's you can't come back without a work note, please, please, please do not require that of our staff members.
Yeah, I absolutely agree. So without going too much further, because we were aiming to do this right at a hard hour, we're going to pause on the questions unless Justin has anything else he wants to add. But we're gonna pause, and again, I'll put it back up on the screen just so that you have our contact details. The info@starguardelite.com is is the easiest way to get hold of us. And if there's anything we can assist with, by all means, please let us know. Please understand, there's going to continue to be more guidance, temperature checks, face masks, all these hot topics, distancing, things like that. We're going to continue to have evolution. Everything about StarGuard and StarGuard Elite is about evolve. It's our hashtag. We use it. We're driving evolution throughout the industry in every way, and that's not going to stop in the COVID era. We're going to continue. Where we're at today is going to be different than where we're at next week, different than where we're at in a month. And it's important that everyone understands it's a continual process, and we will continue getting answers to this.
And then I think the presentation just got posted online, so I'm going to crank out a QR code real quick that I can share of that. And while I'm stalling on that, I'll answer a couple of questions that popped up. Obviously, no masks while people are going on slides or anything that's going to interrupt their ability to breathe, but it may be that we are having them wear masks while they're in line, and then once they get to the top, then they're holding the mask in their hand as they go down, or something, along those lines. And then the question of, if we have a staff or a patron that's positive, then are we closing the facility for 2 weeks? And the answer is no. Work with your local health department to find out what do you need to do in order to reopen. And it might be that you don't even close down at all, because again, the grocery stores aren't closing down just when they get a positive case. So you don't necessarily have to either. So without further ado, here is the QR for this presentation in PDF format. Thank you so much, Jason, for getting that up. I think you have to switch over to.
There we go.
Okay.
So, all right. Well, we will. Craig Sears, one final comment here. I asked about mask enforcement outdoors versus indoors, sunbathing in the corner versus pool deck versus away from everyone, pushback from patrons. Again, all of this is a recommendation. You're going to have to proceed with what is best in your environment, what is feasible, and consistent with your local guidance. The recommendations are just that. It's up to you to make the determination of what is best for your facility. And we hope this information's been useful for you all. This will not be the last time we do this. Please stay in touch with us, like us on Facebook, follow us, and let's stay. We look forward to working with you all. And thank you so much, Justin, for the time. Again, you've been an invaluable resource to our entire industry, and we just can't say thank you enough for all of your efforts.
Yeah, absolutely. My pleasure. And I guess my final thought would be, what you guys do matters. What your lifeguards do matter. And they are, as soon as you open, they are essential healthcare providers that are a valued part of the EMS system, and should be.
Justin, we lost you. Justin, I think we lost you, bud. Well, I'll say I know what Justin's probably saying. What everyone does matters. Everyone is important. We value and appreciate everyone's input. And Justin, thank you so much again. And thank you to all of you. We look forward to talking with you soon. All the best. Have a great day. Stay safe.
All right. Thank you all.